Good morning, everybody. Respected Chairman Sirs, my colleague, at the onset, I'd like to thank Dr. Chikani for inviting me over for this presentation, and my friend, the scientific chairman of the session, Dr. C. Balakrishnan. So, I do a bit of trauma and arthroplasty. So, my brief is to talk on some of the knee replacement patients when they are unhappy. So it's a very humbling experience when you think that you have done a good job and then they come and say that the knee still hurts. Yeah, then how do I go forward here? Okay. Now, I think if go to the introductory slide, yes. So, what I aim to do is look at a systematic approach as to why a patient is unhappy and go about in a systematic manner. So at the end of my presentation, I'll take you through what is the incidence of the unhappy patient in a total knee replacement, what are the causes for this, and with a few case examples, what are the treatment options that I offered when they came to me, and hopefully an algorithm which will kind of suit, have a better understanding on how we are going about it. So this two landmark papers came on 2010, which shook the arthroplasty world, where they said that the figure of unhappy patients, the incidence is about 15 to 20%. So till then we were all kind of thinking that is one of our very successful operations, and all of our results are close to 95%. And so this paper kind of looked at and said that at least 20% of them are unhappy, and they said it's multifactorial. So the intrinsic causes, there could be infection as the first, most commonest, instability, where instability both in the coronal plane and in the sagittal plane, and the loosening of the implant, which could be over a period of years, or if there is an instability, it could loosen earlier. Extrinsic factors could be if the surgeon has not made the correct diagnosis, and if it's a referred pain from the hip or the spine. And time and again, we have a discussion with my spine colleagues to see which needs a priority. Invariably, when you see the x-rays and if you see the wear and tear is much less compared to the pain that the patient is comparing about, I think that's a red flag, and we generally try and keep the surgeon's knife inside and look for other causes. Generally, if the patient is mentally depressed of some kind, it should be worthwhile just getting an evaluation done and counseled before taking these patients. And of course, the patients are being promised the moon, then there will be a problem, and those patients also are likely to be unhappy. So if you look at the literature, that's the sort of figure for instability, loosening, stiffness, and infection that you will see depending on which review article you look. So again, like in any case, how do we go about in a systematic manner? The history. Invariably, the history is about pain and swelling. A knee which was pain-free has suddenly become painful. Is the first symptoms, whether it is acute or late. Acute is more likely pointing to infection. Late is indicating instability or a wear. So again, go about in a systematic manner. Look at the role of CT and MR. So just to kind of bring home certain points, in an extended knee where the capsule is tight, apologize if it is a very basic thing, but I thought residents are there as well. So if you bend the knee to 20 degrees, the capsule relaxes and there is a natural play mediolaterally. And if you do an anterior-posterior just to check in the sagittal plane, how stable the knee is. So this is a normal scenario. And just to bring home a point, in a standing, look at there's bone-to-bone contact. In 20 degrees of flexion, when you open that space, it opens out by that much. So that is the amount of cartilage loss there is and the laxity that is allowed. So when the patient weight bears, the cartilage comes in bone-to-bone contact. So how do we, now that is not normal. When in a lateral view, this is somebody who's had a surgery and the knee goes, the tibia sags that much back. In the sagittal plane, there is a laxity. That is not normal. And when you, oh, sorry. How do I get to play that? So there is again a huge play mediolaterally as well. So that knee is also unstable. So how do we go about a painful TKR because of aseptic loosenings? Now this is a case operated in 2012, post-trauma osteoarthritis. And the pain suddenly started off and on since, remember, somebody who's pain-free suddenly becomes painful. You need to start looking at the cause. There's swelling as well. And if you see, look at the x-rays, you see the pointers that are there, there is radiolucency and the tibia is lifted off. There is radiolucency around the femur, the patella has gone out of sync. Now, all this could be seen in an infection scenario also, but clinically if the knee is not warm, you do an aspirate, then you could rule out infection. And that is what we did. No inflammatory markers were all okay. Look at the knee. It is angulated that much, and that's how he was walking with a stiff gait. The CT was done to confirm the loosening that was there, and they were suggestive of particular disease rather than an infective process. So this is the poly which is worn out, which causes a synovial reaction, and that is the amount of reaction in the synovium because of the poly wear. We used to see this earlier. The newer poly, we don't see it, but this was significant wear in the joint, which needed to be excised. And look at the poly. Half of the poly is totally gone off. So this wear causes us reactive synovitis and giving you loosening and pain. And he needed a very large chunk of poly to give him stability. That thickness of the poly there with the tibial base plate to give him a stable joint. So if the implant is loose or worn out, make sure the poly is the culprit. You always have to rule out infection. Remember, these are late presentations, and they present with history of new onset pain following multiple pain-free episodes. What about instability? Now, this is one of my cases. 2017, for a OA knee, the patient had come and had this surgery. This was an X-ray. Maybe it could be critical and say you left it in a little bit of varus. There is some soft bony reaction in the middle third tibial shaft. Could be a stress reaction there. So this patient followed up 7 years later. Because of the COVID also they couldn't go. This from out of station. And suddenly you have a knee which is opening up hugely on the medial and lateral side. Radiolucency is seen under the tibia only. We did that's the immediate post-op, and that's in 2024. Angulation there, instability seen. And this is what I meant. The leg sags down, and anterior-posteriorly also there is a lot of play. So it's instable in all the direction. The investigation just showed that there is a loosening only in the tibia, tibial component. The femoral component was fine. Aspiration done, ruled out infection. This is how the instability was. And intraoperatively, you can see the arrow pointing that that's where the poly had sunk in on the posterior medial aspect. And the implant was removed, and that was a stability achieved at the end of the procedure. So that's both sides done. The right side was done about 10 days, 2 weeks ago. So if the knee instability, you need to check for stability both clinically as well as look for sign. And it is again another common cause for revision. Infected knees, TKR done elsewhere, comorbidities. This is how the patient, this is my colleague Dr. Aditya Menon, his case, he is interested in infections, and he does the debridement, I do the arthroplasty. So this is how the patient came. This is at 8 weeks. The patient had severe pain, so no prizes for guessing that there was infection, difficulty in walking. This is how it was on inotropic support, counts high, aspiration showed no growths, but the synovial leukocytes were very high, was started on empirical broad spectrum antibiotic outside, and this is how the patient came with. Symptoms had settled down, but there was a lot of pain and swelling. Now in this case, what do we do? Obviously that needs to be debrided as well. It is on the borderline stage. The first 1 month is when we kind of don't be too aggressive. This is close to 10 weeks. Now what do we do at this stage? So we did aspiration, did a biofire, and the report came Staph aureus, and the MSIS score, I'll just touch upon that. The synovial fluid count was 15,000, 90% neutrophils. So the MSIS score suggests that the major criteria, if it's a positive culture or if the sinus tract it's infected. The minor criteria, they divided into 2 groups, less than 90 and more than 90. If the CRP is up, synovial WBC is more than 3,000. Our case had 15,000. synovial alpha defensin level is up, that's 3 points. And in the, if you have a positive culture, is pus seen, then anything more than 5 is infection. So that's the MSIS score. And in a chronic, similar, except that the count, the synovial count has to be more than 30,000. So again, all these criteria, using this criteria, we did a PET scan as well, which showed intraosseous collection. And there was a soft tissue reaction at the bone-face interface. So there is some role of PET scan, but we don't know. There is still expertise being gathered as to the role of it. And we are giving them a feedback intraoperative so that they can gain experience. So in this case, it was a sensitive bug, 10 weeks post-op, just at the borderline, we decided to debride antibiotic and retain the implant. So in early stages, do that. At a later stage, you will have to kind of do a DARE procedure. In an early stage, if you do that, there is good evidence to data to show that these survive. In our case, this, in a late stage, we have to do a 2-stage. We did an extensive debridement, exchange the poly on cefazolin, and this we have ID team fortunately with us to guide us on the antibiotic, and this is at 1 year, patient doing very well, but we got away with it. We're not sure whether we'll get away with just a light one-stage procedure. This is another case, bilateral total knee done in Feb of 23 with a discharging sinus, again done elsewhere. The primary surgeon did a DARE because there was a discharging wound, 4 weeks. And the patient presented in April. Again, came to my colleague. This is how the X-ray was, radiolucency seen. And the aspirate shows NTM. Now NTMs are, my infection colleagues are saying they are seeing worrisome. They are seeing more and more, and these are very, very resistant to treatment. And in this case, we went ahead, did the MRI, which was suggestive of infection. And we went ahead and did the first revision, took everything out, did a cement implant spacer. Again, the infection still persisted. We removed the spacer, debrided, the wound was opening up, so therefore we did a flap on this. Long story short, we put the antibiotic spacer and again a second spacer. And this was at 8 months after the 2 revision and spacer. The aspiration is still gone this. Now what do we do? At this stage, we kind of counseled the patient that it is better to go for fusion. The patient wanted a movement, and we had to go ahead and excise, do a radical excision of a good 6 centimeters of the distal femur. She is now 2 months out. It's a very short follow-up. I don't know how she's going to turn out, but she knows what the outcome is if this gets infected. Lastly, in the infection scenes, there's another patient here. The reason I brought it up is the MRI showed that there is aseptic loosening and PET showed that there is sepsis. So what do we do in such a scenario? The inflammatory markers were all normal. We went ahead and did the aspiration, sent it for biofire, nothing grew. We sent tissues also. Suggestion is to send the tissues also for histopath. And this is the prefabricated spacer we put, and this is the stability that we achieved. But after about 10 days, NTM grew. So now we have to kind of get to the ID people and talk to and see what we can do here. So it's a very challenging and a stressful situation. The algorithm I kind of present to you, the examination markers, inflammatory markers that we have gone through, and then depending on that, whether we do a DARE or a 1-stage or a 2-stage procedure. If it is aseptic, we have kind of shown a few. So what about post-trauma? Now these are very obvious, somebody having a post-trauma, but these are elderly patients. Now these ones need to be fixed and fixed so well that they go weight-bearing immediately. So that this is why we have opted for a combination technique. Now this may not be available for all because that opening in the femoral canal has to be there for an intermedullary rod to be passed. But suffice it to say, when you get them to be fixed properly, this patient mobilized day 1, full weight bearing, and she did very well. Another case, this is done elsewhere, bilateral total knee done. On the 7th day, the patient walked and had bilateral femur fractures. The patient went back in and tried to do, the surgeon repaired the MCL. In spite of that, we had to do a tumor prosthesis, and she is now 2 years out. So this was a very easy to diagnose. And lastly, somebody who has had instability, fracture, and a valgus in the ankle. what do you do in such a case? We first fix the fracture, then do a poly exchange, put a thicker poly, and then fuse the ankle to correct the angulation. So sometimes these are all challenges. So a systematic approach is needed. First have to exclude the infection, correctable causes you have to address, and by determining the root cause, you're very likely to get a reasonably successful outcome. In the aseptic scenario, there are various other components also which I have not touched upon, but that needs to be covered as well. So if you have an explainable cause, in 79–80% of your cases, you should get a successful outcome. Thank you very much for your attention.